Today we will discuss about anti-emetic drugs. Anti-emetic drugs are those which control vomiting or emesis. First we will discuss pharmacology and the neurotransmitter responsible for the vomiting. 5 neurotransmitters are of primary importance in the vomiting reflex. M1 muscarinic, D2 dopamine, H1 histamine, serotonin, and neurokinin 1 receptor means substance P. This is picture of the area postrema. Area postrema surrounds fourth ventricle, outside blood-brain barrier and monitors blood. Area postrema is an important site for M1, D2, 5-HT3 and NK1 receptors, H1 and muscarinic receptors in the vestibular nucleus, and 5-HT3 receptors on vagal afferent neurons. This picture shows vomiting center, chemoreceptor trigger zone, fourth ventricle, vestibular system, central nervous system, and receptors in the gastrointestinal tract and heart. Now, pathophysiology of emesis. This picture is showing pathophysiology of emesis, that how different kinds of receptors are involved in activation of the vomiting center. Anti-emetics classification. This picture shows anti-emetics and their classes and their names. Anticholinergics include scopolamine. Antihistamine includes diphenhydramine, dimenhydrinate, maclizine and promethazine. Dopamine receptor antagonist includes phenothiazine, butyrophenones and benzamides. Serotonin receptor antagonist includes ondansetron and granisetron, dolasetron and pulanosatron. Neurokinin receptor antagonists include aprepitant, fosaprepitant and rolapitant. Glucocorticoids includes dexamethasone and cannabinoids includes nabilone and dronabinol. First class we will discuss is anticholinergic agents. Muscarinic receptor antagonist scopolamine is the major anticholinergic drug that is an effective anti-emetic. It is predominantly used as a prophylaxis agent against motion sickness. Dose is 1.5 mg every 72 hours. Antihistamines are primarily used for motion sickness. Diphenhydramine 25 to 50 mg per oral every 6 hours or 10 to 50 mg IV or IM. Dimenhydrinate 50 mg per oral every 4 hours. Maclizine 25 to 50 mg per oral every 24 hours. Promethazine 12.5 to 25 mg per oral or IM every 4 hours or 12.5 to 25 mg rectally every 12 hours. Sedation is the most common side effect with any of these drugs. Dopamine receptor antagonists. Three classes of dopamine receptor antagonists are used in patients with nausea or vomiting: phenothiazine, butyrophenones, and benzamides. Phenothiazines, they act predominantly by antagonizing D2 dopamine receptors in the area postrema of the midbrain, but also have M1 muscarinic and histamine blocking effects. Prochlorperazine is the most commonly used antiemetic in this class. Typical dose regimens are 5 to 10 mg per oral every 6 to 8 hours, 5 to 10 mg IM or 2.5 to 10 mg IV every 3 to 4 hours, or 25 mg by rectal suppository every 12 hours. Chlorpromazine. Chlorpromazine is used less often than prochlorperazine. The main adverse effects of phenothiazines are extrapyramidal reactions such as dystonia and, with prolonged use, tardive dyskinesia. Acute dystonia can be treated with diphenhydramine 25 to 60 mg IV or IM. Hypotension can also occur, particularly in older patients or with intravenous infusion. Butyrophenones. Droperidol, a short-acting drug, is usually given in the dose of 0.625 to 2.5 mg intramuscular. Haloperidol has considerably longer half-life of about 18 hours, which limits its use. The side effect profile and antiemetic efficacy of butyrophenones appear to be similar to those of phenothiazine. Intravenous administration of haloperidol and droperidol carries a dose-dependent risk of QT prolongation and torsade de pointes. Benzamides. Metoclopramide causes central and peripheral dopamine antagonism at low doses and weak 5-HT3 blockade at the higher doses. It also stimulates cholinergic receptors on gastric smooth muscles and enhances acetylcholine release at the neuromuscular junction, which increase gastric motility. The side effect includes anxiety, restlessness and depression, hyperprolactinemia and QT prolongation. Metoclopramide has a black box warning from the US Food and Drug Administration related to risk of irreversible tardive dyskinesia with higher dosing and long-term use. Domperidone. It is a D2 blocker with selective peripheral activity in the upper gastrointestinal tract. The major advantage of this drug is that it doesn't cross the blood-brain barrier and therefore lack the neurologic side effects of metoclopramide. Now, serotonin receptor antagonist. This table shows brand names of granisetron, ondansetron, dolasetron, indications, half-life, routes of administration, and adverse effect. Neurokinin receptor antagonist. Substance P is a mammalian neuropeptide found in neurons that innervate the brainstem nucleus, tractus solitarius, and the area postrema. The emetogenic effect of substance P are mediated through neurokinin 1 receptor, a member of the G protein receptor superfamily. The oral agent aprepitant and its parenteral version fosaprepitant and rolapitant. They appear to work best when used in conjunction with serotonin receptor antagonist and dexamethasone. They are moderate inhibitors of CYP3A4. To date, the only class of agents that have been routinely dose reduced when administered with these NK1 receptor antagonists are the glucocorticoids. Glucocorticoids. Glucocorticoids are effective and well-tolerated antiemetic for chemotherapy-induced emesis. Their mechanism of action remains to be elucidated. Insomnia, increased energy, and mood changes are common side effects. Dexamethasone has been the most extensively evaluated and is used to the greatest extent. Cannabinoids, nabilone and dronabinol. The modest antiemetic activity of this class of agents combined with their relatively unfavorable side effects, vertigo, xerostomia, hypotension, dysphoria, especially in the older patients, has limited their clinical utility. Nabilone and dronabinol, which is a purified synthetic delta 9 tetrahydrocannabinol, confirmed antiemetic activity superior to prochlorperazine. In contrast, dronabinol was inferior to metoclopramide. Benzodiazepines. As a single agent, the benzodiazepines are relatively weak antiemetic agents. The most commonly used drug in this class includes lorazepam and alprazolam. They are given primarily as adjunctive agents to reduce anxiety and akathisia associated with dexamethasone and metoclopramide, respectively. Sedation is the main side effect. Thank you.